Thank you all for joining us today. We're going to be talking about caring for patients with anemia of CKD, simplifying protocols for personalized patient care. Our first speaker is Calvin Meany. Dr. Meany is a clinical associate professor of pharmacy practice at the University of Buffalo with specialization in nephrology. He provides clinical pharmacy services to internal medicine and nephrology patients at the Erie County Medical Center, where he precepts pharmacy students and residents. His research is focused on anemia management and kidney disease and medication-induced kidney damage. He is also the assistant director of the Advancing Kidney Health Through Optimal Medication Management Initiative, whose vision is every person with kidney disease receives optimal medication management through team-based care, including a pharmacist to ensure their medications are safe, effective, and can be taken as intended. Our second speaker today is Lisa Weideman. Lisa is a nephrology nurse practitioner who's been working with kidney patients for the last 27 years. She currently works at Washington University School of Medicine as a nurse practitioner and manages patients from CKD 3 to 5 on RRT. She's actively involved in home dialysis, TCU, and education programs for our patients and their care partners. I'm Alice Hellebrand, and I'm a member of the committee here for NKF for this conference. And I'd like to thank both of our speakers for joining us today, you all for attending. And right now, Dr. Meany.
All right, so thanks everyone for attending, and thank you for the invitation to speak on this topic. As mentioned, anemia in dialysis patients has been a professional passion of mine since the start of my career, and so I'm really honored to be able to come and speak on this topic. We are going to kind of tag team the presentation today. My job is to cover some of the physiology and pharmacology. I know, shocking, the pharmacist is going to talk about pharmacology. I'm sorry. And then my colleague Lisa is going to go through the clinical applications and patient cases and interpretation of sort of protocolized approaches and when a more individualized approach is relevant. So I have no disclosures. And then the objectives, again, physiology, pharmacology are kind of 1 and 2, and then patient-based approach is number 3. So of course we have some polls. So if you wouldn't mind pulling out your phone, which hurts me to say as an educator, usually when I see phones and hands in the classroom, it means Instagram or whatever social media du jour they're looking at. But use your phones to answer this poll. So who primarily manages anemia at your dialysis center? Is it a central anemia manager, nurses, physicians, pharmacists, a team, or some other combination?
It's kind of shocking.
Yeah. I was expecting some variability, but it's nice to see different folks involved, but seeing a lot of physician management in the dialysis units. I'll say at the units I'm at, it's one of the rare academic freestanding dialysis units. And we currently use a nurse-managed protocol. We sort of use a team-based approach to develop the protocol, and the nurses run the day-to-day protocol at my particular unit. And then just next polling question, just curiosity, which erythropoiesis stimulating agent, or ESA, is used at your dialysis center? Are you using epoetin alpha, so either Epogen or Retacrit? Are you using darbepoetin alpha or Aranesp? Or the one and only time I'll say this, are you using methoxypolyethylene glycol epoetin beta, which I will refer to as Mircera? Good, so a lot of spread here as well. So I'll say, again, my practice and experience has been mostly with epoetin alpha. Our unit uses, now we use Retacrit, which is a biosimilar of Epogen. So it's good to see. So we'll talk about some of the different pharmacologic features of these different agents, how they fit into various protocols, and yeah, so we'll dive in. Brief background, make sure we touch on key points. Diagnosis, pretty straightforward here. This is out of KDIGO 2012. Patient has kidney disease. hemoglobin below 13 in males or 12 in females, right? So this is your diagnosis of CKD anemia. Most patients aren't really going to develop it until GFR falls below 45. Really, manifestations tend to develop more below 30. But this is basic diagnosis. Lots of labs here. This table focuses on the blood counts. I'll draw your attention to hemoglobin. All right, this is where we hang our hat on this biochemical parameter to really dictate and guide treatment decisions, whether that's iron or ESA. Hemoglobin, obviously, our oxygen carrying capacity of the red cells. And then I also draw attention to reticulocyte count. These are immature red cells that, when elevated, really reflect new erythropoiesis, new production of those red cells out of the bone marrow. Can be a useful, sometimes earlier marker of response to ESAs in our dialysis patients. Certainly no discussion of anemia is complete without going through some iron. So again, drawing our focus to two key parameters, so the ferritin, also the storage form of iron. Typically this is elevated in most of our dialysis patients at baseline. It's an acute phase reactant, elevated in states of inflammation, infection, often elevated in these patients, not as a marker of iron stores, but as a marker of that inflammation. But then maybe more importantly is our transferrin saturation, our available iron for erythropoiesis. Targets are shown there. We'll talk about them shortly. Generally above 500 for ferritin and 30 for TSAT are sort of the targets, and that's based on the older guidelines. So again, quickly, background to summarize current clinical practice guidelines. Big air quotes for current, right, because this is 2012 guidelines. I will show you the new guidelines momentarily, but our focus on pharmacotherapy here, we're going to use iron in these patients, especially in dialysis patients. IV iron, IV iron, IV iron. You should not use oral iron in dialysis patients, maybe with the exception of ferric citrate as a phosphate binder. But IV iron, when you need to either increase your hemoglobin or decrease your ESA dose, and that ferritin is below 500 and the transferrin saturation is below 30%. So those thresholds in dialysis patients will likely hold with the new iteration of the guidelines, so it will probably look different in the non-dialysis population. Again, non-dialysis CKD, you could consider oral iron for a 1 to 3 month trial, and then we'll use our ESAs to achieve a hemoglobin not exceeding 11.5. This is really in the US limited to 11 based on the product labeling via the FDA. That's in our dialysis patients. In non-dialysis, it really limits it to 10. So that's, again, more specific to the US. And then in dialysis, we tend to start ESAs as that hemoglobin is in that 9 to 10 range. So what do our new guidelines say? Unfortunately, not yet finalized. So I was very excited, and I've been waiting until yesterday afternoon, and they haven't been published. I'm checking. And I wanted to include information here. But when you open this draft document, it's got a very big red box on it that says, this is a draft. This is for public comment. Do not use it for anything otherwise. So I didn't want to put anything in writing. I will say, though, that some of the changes, so certainly there's a new drug class that's included there, so the hypoxia-inducible factor prolyl hydroxylase inhibitors. I love these long drug class names. They keep me in business. Please keep doing that. So those are in there now. They talk about when to use that versus ESA. Basically, it's a patient individual decision. They do suggest ESAs first because of the long-standing track record of them, but that's really just a suggestion. The major change for iron is really going to be the treatment thresholds and targets in the non-dialysis population. So ferritin below 100 and TSAT below 40, they'll recommend iron there. Ferritin's between 100 and 300, and TSAT's below 25, also an indication in non-dialysis to pursue iron. And then really just an emphasis on identifying and correcting any non-kidney causes of the anemia. And we'll talk about, there's a number of different etiologies of anemia in these patients, and it's really important to address them. And so that's a nice emphasis there. What I really appreciated in the iron section was they have a really nice flow chart on how to manage IV iron infusions. and if they have infusion reactions. So what defines a mild or moderate or severe, when they should be referred, how to address them, should you stop or slow the infusion, give an antihistamine. So there's a really nice chart in there, at least there was, hopefully it stays, to use that we're hoping to try to translate into our bedside use at my institution. So again, not yet published, but should be out maybe by summer, maybe by fall, we'll see. So more to come in this area. So to the meat of the matter, anemia management protocols. Why do we need protocols for anemia management? So this figure shows, let's see how all right. So this is looking at one patient over a year. So the time scale on the x-axis here is a year. Every tick is about 2 months. Left y-axis is hemoglobin, that's your open circles. Right y-axis is epoetin alpha dosing, your closed triangles. So this is a patient from our dialysis unit years ago in one of our studies. And what you can see is that our ESA dosing is very reactive to changes in hemoglobin, right? This patient's hemoglobin went up, we held the dose of ESA, we dropped it, their hemoglobin dropped, right? Then we escalate the dose, hemoglobin goes up. We drop the dose, hemoglobin comes down, right? It's this very cyclical process, highly reactive, lots of variability in response, and again, that's cycling, which as we've learned is a very bad thing in our dialysis patients. So lots of observational data shows that more variability in hemoglobin, more cycling of hemoglobin linked to worse outcomes in the dialysis population. So because of this variability in response, it's really important that we have protocols to help manage these patients. As any bedside clinician will tell you, these are complex patients, right? They've got multiple comorbidities, take a number of different medications, frequently hospitalized, right? Lots of inflammation and infection. So very complex patient population. The pharmacology, as we'll discuss, is a bit unique to these agents, right? And so that leads to a lot of variability in the way that they respond to the medications. And arguably the most important feature is the slow physiology, right? And so we have essentially a hormonal loop here, right? Our kidneys, as we know, sense hypoxia. They're well positioned to do so because they take most of, or 20% of cardiac output. And when they sense hypoxia, it upregulates the hypoxia-inducible factor, or HIF pathway, and that, along with other things, lead to production of erythropoietin. So our rep cells in the kidneys produce about 90% of erythropoietin under normal physiology. That erythropoietin then stimulates in the bone marrow new production of red cells, right? And that's a bit of a process. When that ends and we get more red cells, more oxygen carrying capacity, we shut off that HIF pathway, we shut off erythropoietin production, and that's our normal physiologic response. Unfortunately, when the kidneys don't work or when they fail, we lose renal mass, right? So we don't have those rep cells. And as we've learned in the last decade or so, we also have a very dysfunctional HIF pathway, right? It doesn't respond as it should to hypoxia. And so both of those lead to this sort of multifactorial cause of anemia. Again, those red cells are produced in a very lengthy process, right? So it starts all the way at the beginning with our essentially pluripotent stem cell, which after stimulation by EPO undergoes a number of different changes, begins to incorporate hemoglobin using that iron, eventually becomes a reticulocyte, which is the first cell in this process that's even measurable in our plasma, and then eventually develops into an erythrocyte. So again, in normal physiology, this takes approximately 3 weeks. Patients with kidney disease may be a little bit longer, on the order of 4 weeks or so. So it's a long, slow physiologic process to develop what we need as our biochemical parameter, our drug target, which is hemoglobin inside of these red cells. So certainly, we know that anemia is caused by a decreased ability of our kidneys to produce EPO, but also, as we've learned, dysfunctional HIF pathway, certainly iron deficiency and other cofactor deficiencies, as well as a number of different factors that contribute here. So it's not just one cause. I will draw a little bit of attention to the shortened red blood cell lifespan. So once we make our new cells, someone with normal functioning kidneys, those cells last about 120 days. In our dialysis patients, they only last 60 days. It's about half the amount of time. So not only do we have a patient who maybe has blood loss due to circuit clotting off or other GI blood losses, they don't make the EPO. Now once we get those cells, well, they don't last as long. So now we have a higher requirement of erythropoietin, higher requirement of iron in these patients, which makes the disease process much more severe. So as mentioned, our dialysis patients highly complex. I don't think that's news for anyone in this room, and these I already mentioned. And then lastly, some of the kind of features and characteristics of our ESAs. So these are the current ESAs available on the market in the US. Again, we talked a little bit about them already, but epoetin alpha, branded as Epogen in nephrology, was our first agent in this class decades ago. This one has a half-life of around 4 to 11 hours in IV form. Because of that, we tend to give it either 3 times a week, although it can also be given weekly. It's what we do at my particular unit. And I'll note that if you give it sub-Q, while patients don't like it, it does have a lower dose requirement, which can be cost-saving on a unit-to-unit basis. Darbepoetin has about a 3-time longer half-life than epoetin, so about 21 hours. Because of that, it can be dosed weekly or every 2 weeks. You'll often see in non-dialysis patients an every 4-week dosing schedule as well. And then the last one, Mircera, is the longest acting, about 120-hour half-life. And because of that, we actually kind of have a subclass of ESA, so it's called a continuous erythropoietin receptor agonist, or CERA, because it's very long-acting. So in dialysis patients, it's labeled every 2 weeks. Most places use it every 4 weeks, even in dialysis patients. And again, Retacrit is one of the biosimilars to epoetin alpha. It's available in the US, which is the same dosing, same half-life, et cetera, for epoetin alpha. One thing that I get asked a lot on the inpatient side is how to convert between these. So I stole these dosing conversion charts just from the package inserts, more for reference. But we get a lot of patients at other outside dialysis units on either Mircera or darbepoetin that come in and we need to convert them to something equivalent. So these are listed here. I don't think the conversion is so much often the question as the when, right? When do I give that dose? I mean, really you want to plan on that when their next dose of their routine medication would be due. So either when the Mircera is due or when the darbepoetin alpha is due. I tend to be a bit more conservative. There's lots of ranges here. I tend to select the lower end of the range. Most institutions and units have rounding protocols or usual intervals that they use for the doses of these, so I round to that for our particular institution. But this is here sort of for your info in the future. So put it all together. What does this look like, right? What's a clinical picture of our dialysis patient? So this is looking at a range of hemoglobins from around 7 to up to 13, right? We know in dialysis, we tend to start our ESAs in that 9 to 10 range, and we target, again, a hemoglobin of 10 to 11. Well, why do we target 10 to 11? What's our goal with that target? Essentially, our goal of therapy is to prevent red cell transfusions. That's the #1 therapeutic goal here, right? We're not improving outcomes. We're not even improving quality of life based on the data. I think anecdotally, everyone that's seen these patients get ESAs knows that they can improve quality of life, but the data doesn't show that. Blood transfusions tend to occur in most patients at a threshold of below 7, so we're trying to avoid that. We want to prevent allosensitization, allow for the potential for them to get a kidney transplant. It is Transplant Awareness Month and actually Blue and Green Day, so I selected the right tie today. And so that's why we're trying to prevent those transfusions, among other risks acutely associated with transfusions. And then at the upper end of the hemoglobin scale, why don't we push it towards normal? What we've learned from 99 to 2009 with normal hematocrit, treat, acquire, create, that higher hemoglobin targets have higher risks of things like cardiovascular events, thromboembolic events, vascular access thrombosis, stroke, et cetera. And so we avoid pushing the hemoglobin target that high. So another polling question. Let's say you have a dose increase of darbepoetin alpha in a patient. How long after that dose increase would you expect to see a response, depending on the parameter? Do you expect that reticulocyte to increase within 3 days? Do you expect the hemoglobin to increase in 4 weeks? The red blood cell count to increase in 1 week, or the hematocrit to increase in a day? Oh, there we go. Okay. Great. So 2 points here. One, hemoglobin and reticulocytes, great markers here for our ESAs. Hemoglobin increase, yes, at 4 weeks. I'll show you with some of the dose adjustments in our chronic stable patients, the 4-week measure is the time period to remember, right? Regardless of the agent you use, the red blood cell production takes 3 to 4 weeks, right, to make new red cells. So that hemoglobin, which is in our red cells, is going to take that 4 weeks to see any meaningful change. So that's really what we're looking for. Reticulocytes are, in my opinion, a great marker early on, but they tend to increase in about 1, probably closer to 2 weeks in response to ESA, either increase or dose change or initiation for this patient. So 1 to 2 week scale there. But again, hemoglobin at 4 weeks is really the important point here. And this is when dose adjustments typically are made, especially when increasing the dose to try to achieve your target. So we will have a second question off this, but I wanted to at least show the table. So let's say you have a chronic dialysis patient, they're on darbepoetin alpha, and they've got the following hemoglobin darbepoetin trends. So what dose would they receive today? So for a while they were on darbepoetin 45 micrograms. This was every 2 weeks. Hemoglobin started to trickle kind of down, and then about 2 weeks ago the dose was increased to 60 micrograms, and then today, about that, the hemoglobin went from 8.7 to 10.2. So the question becomes, what dose should we give this patient today? Would you continue it? Would you increase it, decrease it, or hold it? So again, we'll have I think the key feature here is the trend in hemoglobin, and that it, over the last 2 weeks, has increased from 8.7 to 10.2. Okay, so some spread. So we'll talk about this. So I think there's probably a couple of right answers here. And so, holding it, decreasing it, monitoring while on, I think are all viable. Probably doing something because that hemoglobin has gone up by 1.5 points in 2 weeks to reduce the dose. So the guidelines would tell you to reduce the dose by 25 to 50%, as with the package insert. I think some people, if you're on the more conservative end, you might hold it, recheck the hemoglobin next week, determine what to do based on that. But one of those two approaches, I think, would be reasonable. The rate of change of hemoglobin is a really important marker for safety in these patients. And so this is a very busy figure from the FDA out of the normal hematocrit trial, which was published in 1999. But what it shows is the risk of those serious cardiovascular events, so that's on the y-axis, compared to your hemoglobin achieved, so that's on sort of this right-handed x-axis, relative to the change in hemoglobin, so that's on the front x-axis. So here in the middle, sort of the trough in the middle, is no change in hemoglobin over the last 2 weeks. And then as you go out from the middle, the change increases, right? It either goes down more or goes up more. But the trend that's important is that as that changing hemoglobin on a scale of a week increases, so does the risk of those serious cardiovascular events. And interestingly, the group with the highest hemoglobin, which is up in front in the red, actually has a lower risk than the group with the lowest hemoglobin, which is in back with the green. So why is that? Data not shown here is that low hemoglobin group actually gets a very high dose of ESA, right? And that dose of ESA is hypothesized to be related to hyporesponsiveness, and that might be why these patients are having more cardiovascular events. We're escalating the doses, we're not getting a response, and that's leading to a higher risk. And then the trend in hemoglobin change, the trajectory of hemoglobin, also seems to impact this risk. So it's not just that target hemoglobin that we get to, it's how we get there and the dose required to get there, right? This is a post hoc analysis, and this is not how the trial was designed, and there's all those caveats, but some of this has been repeated with the subsequent trials. So what are the red flags? So hemoglobin changes that are dramatic, more than a gram per deciliter in 1 to 2 weeks, that's a dramatic change, right? That shouldn't happen after your initial dose or after your dose increase. Certainly hypertension, right? This augments your stroke risk, but also these agents can cause worsening hypertension. So every unit has a different blood pressure threshold. My unit's is actually higher than this, which drives me crazy, but this is, I think, a reasonable one. And then any new onset of signs or symptoms consistent with either adverse events to the medications, as well as potential bleeding is going to be really important. What are the different types of protocols out there? So broadly categorizing them, there's your empiric sort of algorithmic changes. These are your package inserts, guidelines, increase your dose 25%, increase 25 units per kilo per week, right, if you're not at response at 4 weeks. Those can then get integrated into some computerized decision support software, which I'll show you some examples of. And then we get into more kind of complex algorithms, so individualized biofeedback algorithms. And then now, of course, like everything else, there's artificial intelligence-based algorithms. So as you go down this list, your complexity goes up, the precision of hemoglobin response and then subsequent ESA dose gets better, but the transparency goes down. So that's some of the downsides. So this is just a snapshot out of the Epogen package insert showing these sort of empiric dose adjustments that are suggested. They basically recommend a dose change by about 25% after 4 weeks if you don't have a desired response. Right? They do talk about rapid rises in hemoglobin. Here the threshold is a gram per deciliter over a 2-week period, so to adjust the dose there as well. And then these thresholds we already talked about. Out of the guidelines, they have very similar recommendations for epoetin alpha. The increases based on units per kilo per dose, so that's about 25% for an average dose. Darbepoetin alpha, it's 25%, and Mircera, it's 30 to 50 micrograms per dose. Right? All of them, the increase is at 4 weeks, at 4 weeks, at 4 weeks. So the 4 weeks here is the important piece, and that's again based on that slow physiology of our red blood cells. Dose reduction, similarly, this is in your chronic space every 4 weeks. Right? If you have those abrupt rises, you do want to intervene and do some type of dose reduction. This is just an open source algorithm that takes those empiric adjustments and fits it into a clinical algorithm. I'm not going to belabor it, but it's just an example of how you would fit that into something in terms of the workflow. What I find probably more useful is some type of computerized decision support that takes that empiric algorithm and makes the workflow a little bit more efficient. So this is kind of the example of what we tend to do at my unit. So this is an example of our chart that gets reported out with all the different patients, their trend in EPO dosing and hemoglobin values, and the suggested or calculated dose that would be given per, again, that empiric algorithm. This suggested dose would then be reviewed by the anemia manager. For us, it's one of our lead nurses in the dialysis unit. And they would say yes or no, or I think we should increase it or decrease it, or let's round it to this size. Or no, this patient I know was just hospitalized, we need to do something different. Before that dose is then automatically input into our ordering system. So it just, again, makes workflow a little bit more efficient. One of the nice things here too is that when it goes to be administered, so scan the med to give it to the patient, you can have things pop up, right? So I know we're all alert fatigued, but these can be very useful on the ESA side. So to say, hey, your patient's last blood pressure reading was 180. Are you sure you want to give this, right? Give us some justification, some override. Their hemoglobin last was more than a gram per deciliter higher. Are you sure they're not bleeding? Are they having some occult blood loss somewhere? Or we've increased this dose last month, the month before, now we're increasing again. Or is this patient hypo-responsive? Right, so it can flag these things, and these are all kind of quasi-alerts that we have built in within our administration that at the bedside can be very useful. I think certainly the blood pressure one at the bedside is probably the most applicable. For us, the other two actually show up on the anemia manager verification side. So this is just a nice way to use our EMR to help us with some of these decisions. Now into the fun things. So personalized or biofeedback-based approaches get more complex, right? So this was a project I worked on in our dialysis unit a few years ago in combination with a PhD student in pharmacometrics that was looking at ways that we can, one, predict patient response to hemoglobin, and there was a lot of things that went into that, basically what feeds into the system, what feeds out of the system, how do we calculate and predict those rates, and then how do we predict what hemoglobin will be. But to me, the important piece here was feeding that prediction back into our dosing, right? So we call this adaptive feedback control. So within one patient, as I predict their hemoglobin, I make that adjustment to the ESA because of what I predicted, not what happened, but what I predicted. And then over time, my prediction gets better and better and better because I learn more information about that patient. I refine these various estimates, and my estimated dose gets better and better. So what does that look like? Well, that looks like some of these patients. So each number is a different patient. A was kind of learning phase, B was simulation phase, and then the shaded bars are the confidence of our prediction or our estimate. The take home here is that as we improved, right, as we taught the system and learned from the patient, adding more data for each patient, we improved our precision. So our precision error went down from 11% to 3% and continued to improve, right? So we got a much better idea as to where their hemoglobin would be and therefore what dose we could use. So this is an individualized, personalized algorithm. And others have done this as well with good results and good precision. And then the most complicated now is our artificial intelligence protocols. And this is an example from South Korea. There's other examples from Japan. Some of the larger dialysis units do these as well, where you're using patient data, population data, feeding it all in, training a neural network or some other type of network, and then coming up with dose recommendations, dose decisions. And this one I liked because they had a transfusion alert or transfusion alarm, which was helpful. While I understood most of the biofeedback one, I understand none of this one. So that's my major problem with these, is that it's effectively a black box, right? So at the bedside, I get this, hey, AI says give this dose. I don't really have a good sense as to how they came up with that recommendation. I don't have a good understanding of what that means at the bedside. So my trust in it isn't as strong. And I think that's a major barrier to its implementation. But I will say is that in the validity process, these types of algorithms are becoming more common, and they're not going away. And so I think we need to just make sure that we validate them in our patients using simulations and then some clinical trials before we really implement them in our patient populations. So what were some of the algorithms out there in the literature? This was a systematic review a few years ago of algorithms showing the percentage of hemoglobin target attainment depending on each individual study. Purple is before algorithm, orange is after. And you can see across the board they tended to get better, right? Hemoglobin attainment got better. Other findings were that hemoglobin variability goes down. That was consistent across almost all of the studies. The dose of ESA required goes down. Right? That's a good thing, right? We tend to use other agents like iron or other, reverse other causes. And so that was potentially cost savings and or adverse event savings. The trouble is in those protocols, they really only incorporated our ESA doses, our hemoglobin trends, and then our iron parameters. Only 2 of them had red blood cell lifespan in it, which I think is important in these patients because it can be variable patient to patient. But very few had parameters beyond that. There was one that was a quasi-AI model that had a lot of parameters, which was great, but they're really not integrating some of the other factors that are important in the decision-making process. So again, advantages of protocols, generally speaking, less variability in hemoglobin, lower doses of ESAs, potentially cost saving. And it's nice to have that systematic approach. It can streamline workflows. It can make our lives a little bit more efficient in the clinic. Disadvantages, they're missing other variables in clinical context, right? They're not looking at the patient like the bedside clinician is. They assume the same target hemoglobin, so it's hard to change that depending on a rigid protocol. And again, some of the algorithms are very complex and the methodologies aren't clear at the bedside, and that can lead to distrust in them. We don't know that they have any improved clinical outcomes, though I would argue that's also true for the use of ESAs as a whole, aside from preventing transfusions. And anytime we have a protocol, it's a universal approach we apply to all patients. It's going to fail individual patients. That's the nature of a protocol. So we just have to keep that in mind and appreciate when our patients need to deviate from the protocol. That's what we'll talk about shortly. I've mentioned this already. These are our goals. Number 1, prevent transfusions. Number 2, prevent adverse events. That's it. So at the top of my mind in these patients is always, am I putting them at risk of an adverse event because either I'm increasing their ESA dose too much or their hemoglobin is changing too rapidly? I think about those a lot when we make dose decisions. And that really matches with what KDIGO 2025 says, which is that give ESAs at the lowest recommended doses to maintain your treatment goal, right? This is consistent with what they say currently. So I will leave you with this, right? So you have a patient, let's say you're in clinic, your patient presents, their hemoglobin's 9.1, they're due for a darbepoetin dose. The anemia protocol says, hey, increase their dose to 100 micrograms, right? You can say, okay, let me get my darbepoetin, let me give this patient 100 micrograms. Or you can think about the patient that's in front of you, right? So treat the patient, not the number, which is what we're going to talk a lot more about momentarily here. So this patient happens to be my grandmother, who was on peritoneal dialysis for the last 5 years of her life. She had a lot of struggles with anemia and had repeated dose escalations of Aranesp, repeated dose escalations. And unfortunately, she had a strong vascular history, had peripheral vascular disease with stents, extensive cardiac history, very high blood pressure that was hard to control. And eventually, she had a stroke, right? So it was one of the major adverse events that we were trying to prevent, but we just kept saying, hey, her hemoglobin's not 10 to 11, go up on the dose. It's not 10 to 11, go up on the dose, right? And so if someone had stopped and said, well, let me look at this patient, let me think about the whole context of this patient and what I'm trying to do. I'm trying to prevent transfusions. You're not going to transfuse her at 9.1, right? I want to prevent the adverse events from this drug. So always keep that in mind. Treat your patient, not your number. And she was lovely. She lived till she was 89. Had 20 grandkids. I can't even keep track of them all. And I'm one of them. So, anyway. So in summary, for me, anemia is multifactorial. I think that means multidisciplinary approach is really warranted to address that. ESA is really unique pharmacology, and that delayed onset of effect is due to that slow physiology, right? So you have to think about both facets. Management protocols can help us improve target attainment, reduce costs, reduce variability, but you have to recognize that these protocols will fail individual patients and when to deviate for the patient's best interest. And based on that, we'll go to the next presentation.
Perfect. Thank you. Wow, I've got a lot to manage up to here after Calvin. I appreciate everything Calvin presented to us. I really wish Calvin can come to all the dialysis units I work at and do lunch and learns. Because, the lunch and learns, I've been in renal since 1995-ish. So the lunch and learns have gone away, which is unfortunate in the dialysis units and for whether you're home dialysis or you're in-center dialysis. And so this knowledge just doesn't get there anymore. And that's what's most unfortunate, I find, because I round at 13 different dialysis units, all the different flavors that are out there, as I call, all the different LDOs, independents. I work for an independent. But again, my assessment over the years is that this understanding of you're giving an ESA. Why are you giving an ESA? Or you're giving an iron. Why are you giving an iron? And that's what I think these pieces are missing. And, when new nurses come in or existing nurses have to do education, it's usually, computer-based where you're you're going through on a computer, and you're just tapping the next button and looking at Instagram, right? And trying to get understanding, because I think if they had this base, this knowledge of what Calvin just explained, I think it would be tremendously beneficial in patient care. And it's just, I find it, and it's disheartening to me that it's not there, and some of the organizations don't promote. I remember when I gave my first dose of Epogen in, I think, 1994, and somebody's hemoglobin was high. And oh my gosh, I was like, oh my God, yeah, big trouble. I'm giving Epogen, which is expensive, and the hemoglobin's high, or hematocrit. We did hematocrits back then, and we spun them ourselves in the dialysis units. And it was like, okay, ding on Lisa, because she did that, and I didn't look at everything, and I remembered it despite the fact of getting some education. So trying to re-educate is so important. Even nurses who are very seasoned nurses and new nurses and seasoned nurses extending this to the new nurses. I think it's just so vital. So Calvin, thank you very much for that. And I wish you could come into all the clinics that I go to. So I have no financial disclosures. My objectives are very similar to what Calvin presented earlier, but I'm going to put the practicality side to it. I'm going to be the in the trenches, what's going on in the clinics, what's going on with our interdisciplinary team. The IDT is what I'm going to refer to it as, and what's going on with the patient. Right? Let's dig deep into how we're going to manage this for our patient population. So Nancy Spreith, I don't know. I know Mike Krause is in the audience, and he knew Nancy, and several people have known Nancy. She was a home dialysis patient, and she used to come to all these conferences, annual dialysis conference, even NKF, and she used to always go up, because Calvin, you made this comment about protocols, and it says there's no link to clinical outcomes. So Nancy would have got up and just been at that microphone and said, okay, what's the clinical outcome for me? For a patient, because she's talking from that aspect. So I found this and I was like, oh my gosh, I've heard Nancy, scream at the top of her lungs about how she felt and home dialysis made her feel better. But it was so real because it was Nancy talking about her life. And then I found this on a blog and I was just so thrilled when I was trying to prepare this presentation. So Nancy was one of the first patients to get Epogen in 1987. So I will read what she wrote. Before dialysis, when I was 15 in 1963, I took first place in skiing in a co-ed slalom race. I beat the boys. 2 years later, I couldn't even walk to the lodge to the lift. I started on dialysis in 1966. I don't remember how many transfusions I had. It was many, at least one per month. I've highlighted in black, I had to be desperate before the doctors would consider giving me blood. So I was part of a phase 3 trial in 1987. I was on home dialysis, raising 2 children alone. My hematocrit was between 11 and 15%. I couldn't walk up the stairs. I had to crawl on my hands and knees because I was so out of breath. Once I started on the drug, I could tell that there was a change within 2 weeks. So maybe not the 4 weeks, but the 2 weeks. But again, but considering her hematocrit was 11, within 30 days, my hematocrit was 40. So maybe we went too fast as you talk about it. But my daughter said, all of a sudden you were up and going and eventually I could run upstairs. I used to be asked, what are you doing? I answered, what can I do? My body has me in a prison. Epogen changed all of that. What a difference it made in my life. It just dug at my heart when I saw this. I also think that what changed in her life was the fact that she did home dialysis, more frequent therapy as well, because there was at one time that was taken away from her and she had to do in-center and she just felt miserable. So I think it was a combination, but this just shows somebody who had to be required to get transfusion. So I really wanted to bring that to the attention because then it leads to my next slide, which is totally patient-centered care. Right? It's about the patient, of course, and we talk about this patient-centered care. We hear it. I almost every lecture I've been to here at this conference is about, the patient in the center, patient-centered care. And I think when you look at that as working in a dialysis unit or working with ESKD patients on dialysis, you're surrounded by all disciplines. But you also surround it by their care partners. And sometimes I think the care partner gets grouped in the center with the patient, but really they're part of the interdisciplinary team taking care of their loved one, their patient. So again, we got our dietitians, our nurses, our PCTs, our social workers. Sometimes when you think of anemia, you think of medicines. This is all nursing, right? This is provider giving a prescription and a nurse administering the medication. But no, all these disciplines play vital parts in anemia management. So symptoms, and you have to weed out symptoms, right? Because you have a patient who comes into dialysis and you're doing your assessments and different things like that. Or the social worker might be doing her KDQOLs and looking at, depression screenings, different things like that. RDs might be talking to them about their appetites, nutrition, all this stuff. So it all filters into everything we do every day with our patients. But patients will feel tired. They'll have low energy, they're weak. But is there low energy because they're depressed because they're on in-center hemo? You have to weed out all of this stuff. Chest pain, could it be chest pain because they forgot, they have too much volume on, they're hyperkalemic, Ks are high. Shortness of breath during activity, is that because they're volume overloaded or because truly their hemoglobins are low? Bruised skin, a lot of patients are on anticoagulations. Difficulty remembering things, sleeping, lack of motivation, need for frequent breaks. So all of this is, can this be considered anemia or what is it? And so it's very challenging to weed out the symptoms because as Calvin said, our patients have so many comorbid conditions that it's challenging to do that. So I'm going to jump right into a case. Mr. C. So this is a patient of mine who started, a 55-year-old male who started in-center hemodialysis in August of 23. And so he had some developmental delays. And so he lived with his mom, and his mom worked as a full-time school nurse. And in August of 23, when we were looking at his labs, he was very well taken care of in CKD clinic. His hemoglobin came to us at 9.5. He was on Procrit before he started with us. His T-sats were 31. His ferritin was 334. So, here I'm managing this patient. He's no longer going to be getting outpatient ESAs. He's going to be getting in the dialysis unit ESAs, which was a different formulation because in this dialysis unit, they give Mircera versus what he was getting in the infusions, in the infusion center. So we started him on very low dose ESA and low dose weekly irons. So if you kind of trend, his hemoglobin went up in September of 23, didn't really make any changes because it's where I wanted it to be, right? But did I ask Calvin if he felt any better? I didn't ask those questions, necessarily, but I saw a nice trend. And then in January of 24, it went up to 11.2. So of course I'm reducing the dose, right? And I found it very interesting when Calvin did his first question to everyone of who manages anemia. And I was actually uber surprised at the amount of physicians that manage anemia. And I kind of want to weed through that, not just because I'm an APP, but is it the fact that with anemia protocols, physicians have to sign off on the orders? Or I'd like to know it if the physicians are really dissecting every piece of anemia, or do you have a manager that presents that to the physician? Because all orders have to be approved, right? So if you have a centralized anemia manager, if you have these computerized protocols, obviously it's all going back through your EMR or a verbal from your physicians. So again, a part of the interdisciplinary team approach. So we reduced the ESA in January of 24. In April of 24, hemoglobin went up to 12. Obviously we held. T-sats were 29 and ferritins were 311. So then in January, hemoglobin's 11.1. We restarted on a very low dose because I was like, okay, he went from 12 to 11. What was going on? In February, it went down to 10. The protocol said to increase the dose. I'm a very hands-on person, so we do have centralized anemia managers. I want to know everything though, so those centralized anemia managers know they should run things by Lisa because I'm part of the team. I see my patients 3 times a month and the physician sees them once a month. And usually the nursing staff, the RDs and the social workers call me because I see the patient most frequently. So increase the dose. We also increased frequency. But one thing that I did do is talk with the interdisciplinary team, like, has there been any blood loss? Does he have prolonged bleeding? Have you lost a circuit? When you check the hemoglobin, did you check it on a Tuesday or a Thursday? What was the interdialytic weight gains? Just one of these other things, like was it delusional? Different things like that. So I changed, because I'm pretty aggressive. I said, I want to check his hemoglobin weekly just to see what's going on here, because I'm just, that's just who I am. But his iron level stayed stable. Well, then in March, in 2 weeks, hemoglobin continued to go down. Chatted with the patient. He vocalized really no symptoms at all. More aggressive increase in the ESA. Didn't necessarily wait. But then a week later, because I went to the weeklies, his hemoglobin was 7.4. Still, and my collaborating physician saw the patient for his MCP rounds. He asked, Mr. C, hey, are you feeling bad? Anything going on? Have you noticed any blood in your stools? He asked the team all the questions like, something going on, did he lose circuits, different things like that. We gave him some stool cards. But at the end, we did the assessment, and one thing that I asked is that, did the circuit look like Kool-Aid, as I call it? Because in the old days, I always knew when someone was bleeding because it would look like Kool-Aid. Your blood lines would be very, very light. I'd call it Kool-Aid, and I'd be thinking, okay, this guy, is he actively bleeding? What's interesting is that the protocol through the centralized anemia manager didn't kick in a retic count. Like when we started to trend down, their protocol was very well defined when a retic count, it had to be so many weeks and so much decrease. So I repeated its stat the next, I tried to get it the next treatment, and our stat lab, is a 6-hour turnaround time because we're not, it's not next to a hospital. So his hemoglobin came back at 7.2. So I immediately called Mr. C. He didn't answer his phone. So I called his mom, who works at a school, and I told her, I said, hey, Doug's hemoglobin is 7.2. He needs to go to the emergency room because it's been trending down. So goes to the ED, gets transfused. They don't work him up at all. They just turf him back to his PCP or back to us. But the whole point of this is that the mom apparently called the dialysis unit and said, Doug is feeling really tired, sleeping all the time. And she had called a couple weeks ago, but no one had really talked with me about that. Or it wasn't, transcended to me, different things like that. But he kept it, and I said, okay, well, I'm sorry, Sharon, but he denied any problems to me or my collaborating physician, different things like that. He said he didn't have noticed any blood in his stools. And she said, well, Doug has lost his vision more and more. So he wouldn't have been able to tell this. And so again, Doug is a little bit developmentally delayed anyway. So how does this pertain to incorporating patient-centered care, right? So if you look at all the disciplines, so the nurses, nursing are getting the labs, right? Labs are hopefully being called. With a centralized anemia manager, they will automatically get that hemoglobin that came back at 7.4, notify the team at the dialysis unit, they will notify us, their assessment. Going to the PCTs, looking at any events that occurred on dialysis, right? Or anything that Doug might have said to the PCTs, because your frontline people are your PCTs at the dialysis unit. They bring them in, they put them on the scale, they walk them to the chairs, they talk to the patients, right? An RD, how can a dietitian play a role in this? Well, could she looked at protein levels? Could she looked at NPCR, seeing what was going on? Engagement with a social worker. Would the social worker picked up that Doug has been feeling tired, been feeling more weak, not engaging in activities that he normally would engage in? And of course, we have our provider, which, with diagnosis, management, and ordering. So lessons learned that I learned from this, and it was Sharon, who's the mom, who is also a nurse, put me in my place very well and said, if you guys would have just engaged with me. So understanding the total engagement of that part of the care team, as opposed to just us at the front lines looking at labs, potentially maybe not asking Doug, and believing what Doug says, but Doug he never complains about anything. And we probably should have known this about Doug because we've been taking care of him since 23. He never complains about anything. So again, if we see things like that, our reaction should be, maybe I should call the care partner. And because they're really a part of the team, and I could have potentially figured out and prevented this from going that way. So optimal anemia management. So if you take a look at that, you've got this patient, and Calvin had gone over this, but so we look at obviously iron, we look at ESA therapies, but the biggest thing is individualizing it. And I think that's what's most important. And individualizing it because, Calvin talked a lot about this hemoglobin variability, getting stable doses, not being so reactive. But again, that takes a team to understand all of that, to understand, what's really going on with these patients. So Calvin touched on this a little bit. I think I found it very poignant because I presented Nancy at the beginning, because these improvements, everyone is different. Calvin, your grandmother might have been fine at 9, and not had any change of quality of life between a 9 and a 10, but you guys were pushing 10 to 11. So talking with patients about, how they're feeling, this better quality of life, different things like that, compared to the risks, as Calvin talked about with his grandmother, these risks of these CVAs, this vascular access, all of these mortalities, you really have to weigh it. And I find with anemia, you have to be tremendously patient. You need not to always do these knee-jerk reactions. My biggest knee-jerk reaction is I want to repeat the lab a lot, because sometimes I just don't believe labs. And I just think there's a lot of variability with labs. How did it get drawn? Is it the right patient even? Was it labeled correctly? I mean, I kind of just go into the worst places. So again, looking at that. So Calvin spoke about this, but I think I live in the world with a lot of anemia conversation at WashU, working with one of my colleagues who called ESAs to the carpet way back when about, using too much of them and reporting it to the New York Times. So I live in this world of looking at scrutinizing ESAs. But, when we talk about weight-based dosing, and Calvin didn't get too much into this, I mean, I'm not going to go through the first part of it, but the second part of it is that, I find it interesting, a lot of these anemia protocols, you might have a 70 kilo patient whose hemoglobin is 8.2, and you have a 70 kilo patient whose hemoglobin is 9.8, but based on their weight, we're starting at the same doses, right? And so you say to yourself, where's the thought process to all of this, but if you look at the actual dose required to achieve target hemoglobins, there's so many more factors beyond weight, because I always see this happen all the time. So again, echoing what Calvin said about these iron stores, but having staff understand and looking, well, why are we looking at T-sets? Why are we looking at ferritins? Some protocols will have you draw T-sets every month. Some protocols will have you draw T-sets every 3 months. Ferritins are usually every 3 months. Some protocols out there will say you're going to draw a transferrin saturation based on their hemoglobin and based on the trends of the T-sets. Again, these computerized things are great because then it kind of kicks in. But what do you do with that information, and who's evaluating that information? But it's critical. Inflammation is so key. So chronic inflammation, common in our dialysis patients, can cause a lot of different responsiveness to ESAs, but understanding your patients. So if you don't see your patients frequently, maybe once, twice a month, do you know that they go into the hospital? Do you know what's going on with any type of inflammation? Do you know any new diagnoses that they've had based on their providers and other parts of the team? Because as much as we're part of EPIC, which is an EMR system, and we want everyone to communicate in EPIC, I can get a patient with a new diagnosis of cancer, and we're all part of the WashU system, but there's never a note that comes to nephrology that said, hey, your patient has cancer now, or your patient has this. I would, in the hopes that they would copy us on those things. So you have to be a detective. You have to dig deep. But the biggest way to be a detective is to talk to your patients. So when you see this hypo-responsiveness or what's going on with the patients, talk with the patients. Have you seen a different provider? Have you been newly diagnosed with something? Different things, just having conversations. Well, I can't be there all the time. So making sure your interdisciplinary team reports those things back to you, I think is, again, essential in anemia management, because they are listening, they see those patients more frequently and communicating as an interdisciplinary team. Adequacy, that's one thing Calvin didn't talk about, was adequacy. So if you're not clearing uremic toxins, and they're not getting good flows, they're just not meeting their kinetics, can this attribute to anemia management? Absolutely. I manage CKD patients who are uremic and they have anemia of CKD. So again, understanding these uremic toxins and getting baseline hemoglobin starting at low levels may require a higher dose initially. I love it when we get our CKD patients who've already, if they were sub 10, who came to us and already on some sort of ESA. It's on your 27, 28. You have to mark it if they were receiving ESA dosing, because usually those patients are just beautifully managed because they've already been exposed, they're already on some low dose ESAs. We don't believe in oral iron, and our CKD population, we're big IV iron users, honestly, so we don't have to give ESAs in CKD. But again, those patients who are just kind of like, all wrapped up nicely when they have to come to you because they were already managed are just so much more stable as the patient who crashes into the ER with hemoglobins of 7.5, need to start dialysis, T-sets of, 9, ferritins of, 86, just really not managed at all. So titration, Calvin talked about this, but I think the whole point is that, look, I want to do this typical dose range in practice. When we look at this, and for patients who need higher doses and different things like that, looking at the variability when it comes to the weights, I think is just so important compared to just putting them into the same classification. So individualizing, that's what is the key. And to summarize this a little bit is that, while you dose ESAs based on weight estimate initially, you have to do a dose to weight relationship, which can weaken the whole treatment progress, is what I call it. Achieving these hemoglobins relies on, again, I can't overemphasize the individualization of care and for precise dosing when it comes to hemoglobin trends and guidelines. So again, just echoing the individualization. Calvin talked a little bit about iron protocols, so I'm not going to get into too much on that. But what I do want to talk about is when we think about alternative therapies to anemia, when we look at iron-based binders. And he did mention a little bit about ferric citrate, but if you have patients who you're having resistance and need, or have actually some intolerance to IV irons, that can we use iron-based binders, and we absolutely do. We seem to have a higher penetration of use of iron-based binders in our PD patients because, you know, our in-center hemos and even our HHDers are easier to give them IV iron. But with our PDers, they come in once a month. We have to give them a dose of iron once a month as opposed to our hemos where we can give it more frequently. So we do tend to use, and I don't know if that can be echoed or seen in our population here today listening in the audience about using iron-based binders in home dialysis patients. But what we find is that it enhances the absorption of iron. And reducing the need for IV therapy, IV iron therapy. What I always tell patients though, when we start iron-based binders, look, your stool's going to look differently. So don't freak out when you see a discolor, your stool looks dark. You're not having a GI bleed. Yeah, but we do watch out for the patients who have a history of GI bleeds. What we find is when we use iron-based binders is that we can see a decrease in EPO use or ESA use based on the iron stores. And there's a cost savings because you're not using iron or ESAs as frequently. So obviously the two that are out there are, you know, the ferric citrate and then the Velphoro, the indications, the precautions with people who are in iron overload. The biggest I find side effects of these is the GI distress with them. So I start low and slow, especially with these patients because so they can get used to it. It's not a race, you know, and if you start low and slow, I find that they can actually tolerate the binder better. I mean, I'm not going to just shove, you know, 3 of them, one at least with the Velphoro, 1 tablet with 3 times a day with their meals, or the Arixia which is, you know, 1 to 2, 3 sometimes with each meal. It's just a huge burden. Again, we can go slow with this. So I just wanted to show some alternatives to managing anemia in our patients that might not be responsive. So changing gears here a little bit is the role of the nephrology nurse, because this was part of the objectives looking at the nephrology nurse nursing into anemia management. So assessments early on, understanding the labs, understanding trending. But what I have found a disadvantage of a centralized anemia management or computerized protocols, or even AI, which is in the black box, and I don't understand it either, is it takes the nurse out of it. The floor nurse, the staff nurse necessarily, understanding things. Because and I'm not bashing centralized anemia managers because we have a lot of absentee landlords out there, as I call, you know, people who don't see their patients on dialysis. So I understand why these centralized anemia management protocols had to be put in place because otherwise they weren't being addressed. Or if you have, you know, an anemia manager in your unit, one anemia manager for your unit. But when it's just centralized, and the centralized will kick it out and say, okay, it automatically increased the Mircera dose from 45 to 60. And the nurse gets it and realizes, oh, okay, this is the dose I'm going to give today. Does the nurse have the time to go back and see why we did that? And I think that is just so wonderful of an understanding, because that way, when you talk about patient-centered care, it means talking with your patients. Mr. Jones, you used to get 45 of Mircera, but now you're getting 60 because we're seeing a trend down in your hemoglobin. And if you ask people what anemia is, your patients, you know, I do a lot of CKD education. So I do it early on when eGFRs hit 20, and we talk about all aspects of CKD. But anemia is one of them because we talk about what are the functions of the kidney. Well, one of the functions of the kidney obviously is to produce a hormone that creates, you know, for the stimulation of your red blood cells. And so if early on, if patients know this, and then if they get to a kidney replacement therapy like dialysis and they have that understanding, but they want to be on top of that, right? You know, and if you say to your patient, well, your hemoglobin is not responding the way it wants, or it's trending down, maybe that would stimulate your patient to say, you know what, when I wipe myself, I've noticed a little blood on the toilet paper. Or, you know, I've been having some gum bleeding. Or I just recently had all of my teeth taken out and I've been back in the EED twice because my mouth is bleeding so bad. So just different things like that. It stimulates the conversation. And so bringing the nurse into that conversation is vital. Because it applies to patient-centered care, right? And so it's just crucial not to take the nurse out of anemia management or that part of an assessment as well. Reporting. So when you get things like, if you know things like they've been having prolonged bleeding, they're losing circuits, just other things that the patients are reporting to, who are the nurses reporting this to? Or, you know, and how are we managing it? Administration and documentation of medications, that's essential too. Obviously, charting of events. So I am exposed to a large dialysis organization that does use centralized anemia managers, and their centralized anemia managers take care of 2,000 patients. Yep, 2,000 patients. And so I'm a control freak and I'm on top of it all the time. But I talk to some of these centralized anemia managers and they say the worst thing that they have to play detective because there's no documentation in the charts. You know, because do the nurses have the time to say, oh yeah, they lost a circuit? Did the PCT tell them they lost a circuit and they can document that? Or some event happened, because then they have to truly be a detective on all of it. So charting everything, you know, documentation is so crucial to anemia management. It really, really is. So the involvement is essential as a role of us nephrology nurses. So again, this is the way, you know, Calvin kind of talked about it as well, but it all has to be where the nurse is truly in the center of it, you know, because we're giving the meds. We're documenting that we're giving the meds. We're putting our licenses on the line to give these medications, and we should know, you know, what we're giving is at the correct dose and what's going on with it. So again, bringing the nurse back into it is what I hope to see, and I empower the nurses that I work with to be on top of it. Absolutely, because when I make anemia changes, sure, I will work with the centralized anemia managers or the anemia manager in the dialysis unit, but I will go to the staff nurse, the charge nurse who's taking care of those patients and say, this is why I did what I did, or this is why I want to give, you know, a gram of iron, different things like that, because where's that communication? So when you look at the IDT involvement, so you have a brand new patient who comes to your unit, right? You're looking at the labs from the CKD clinic or the labs from the hospital if they crashed in the hospital. Of course, you know, you're trying to get a picture of these labs, and you got these crashers who come in who are really uremic because they had no idea that they had end-stage kidney disease. Look at the medications that they're on, and it's the due diligence of the provider to know if they got any ESAs beforehand, again, because of that 2728, and reporting that. The nursing assessment, so the diagnosis, past medical history, are they on blood thinners? You know, have they had a history of GI bleeds? You're doing all of this with your nursing assessment, right? And then you do a plan of care. When that's the interdisciplinary approach, is a plan of care. So when your patients get discharged, do your patients get ESAs in the hospital? Mine do not. And I love that Calvin's might get it and they look at it and they change the doses and stuff. Our hospital system is not that great to do that. They're not on top of it because our patients go to a lot of different dialysis units. Some of them are at our own units, and if they're at our own units, we can see in Epic what they were getting. We give Aranesp at our own units, but you know, some of the large dialysis organizations give Mircera. So converting that and knowing, and then it's unpredictable how long they're going to be in, when they got the last dose. How did they dig deep? Did the renal fellows, did we dig deep to know what was their last ESA dose and when are they due again? But when the patients come back to you, I mean, I've been doing this a very long time. Hemoglobins are just dropped. When you get labs when they come back from the hospital, you know, you could have been rock solid with hemoglobins 10.6 on very low dose of ESAs, maintenance iron, and then they come back to you and their hemoglobins are 8.8 or 9. Well, sure, they had an event that ended up in the hospital. So looking at these records, looking at new medications, looking at diagnoses as well. And that just doesn't have to be nursing. The social workers, the dietitians, we can all weed through these medical records. Having a discussion with the patient, I think, is most essential because usually they know what happened in the hospital most of the time. And then I always get labs right when they come back. Sometimes I don't know a patient that comes back. Like they're like, hey, Lisa, did you know Mr. Jones came back? Well, no. Okay, how long has he been on the machine? He's been on the machine an hour. I'm like, okay, well, I can't get labs, but let's get labs the next treatment. You know, because sometimes they just end up in your lobby because you didn't get any discharge summary or any note from case management at the hospitals. So I find it so very essential to get labs when they get back. And then your current patients, obviously, you know, you're looking at their labs monthly. You're looking at their medication. You have ongoing assessments, management, reporting, and involvement of the patient and the interdisciplinary team. So I'm going to get to another case, my Miss Rochelle, as I call her. So she's a 53-year-old female with ESKD secondary to hypertension and diabetes. Followed in CKD, creatinine was 7.9, eGFR was 12, hemoglobin was 13.2, TSAT was 33%, and ferritin was 159. So she just felt very symptomatic. She felt tired. She worked full time. She felt like was in this brain fog. She couldn't work as she had decreased appetite and just overall feeling fatigued. And the one person who told us that they saw a real decline was her daughter. She's actually one of my CKD patients, and said, you know what, my mom's just not doing well. I think it's time. And she was slotted to go to peritoneal dialysis, but ended up on in-center hemo. To not wanting what I wanted to do, but it's not about me. But maybe I'll get her to transition. But she just felt so miserable that the bottom fell out pretty quickly. So she opted for in-center hemo, initiated in February of 25, and her weight was 78 kilos. So these were her trends with hemoglobins after she started dialysis. So she was in the 12s, 11s, 11.2, 11. Her TSAT was 23%, 171. So it had gone down after she started dialysis. Retic was 1.67. IPTH was 436, and she was started on vitamin D actually in the CKD clinic, and it transcended over into the dialysis unit. So you think about management, right? If you're looking at this as an interdisciplinary team approach, what would you do next with this patient? And I didn't do any fun polls like Calvin did because I'm not as fancy. But what would anyone just want to throw something out? So she's sitting in your chair at the dialysis unit, and you're seeing her trends going down, but like this is a brand new patient. So anyone? All right, well, I'm gonna tell you what I did. So we started to give her iron because her TSAT, because her hemoglobins were trending down. She did go from 12.6 to 11. We had some catheter issues is what I found out. So she did lose a circuit of blood because she presented with a CVC as opposed to an access in her arm. And so I thought, okay, well, the TSAT's gone down to 23%, her ferritin says, let's see if I can just manage this with iron. And so that was our step, what we did. So, when we did that, her hemoglobin did respond. Her TSAT responded, and so did her ferritin. So again, you don't have to go straight to ESAs, and I think that's what Calvin was talking about in some of the protocols that he talked about. Iron is a great tool for us, looking at iron deficiency, and going to iron with the management. So, then further management was to continue, obviously, to monitor her labs, maintenance, low dose iron weekly. And so I was able, I've been able to keep her just like that, to be honest with you. She was February 25. I know it's only, in April, but still I haven't had to start her on ESAs in the in-center unit. So that's just a really simple case where you don't have to say, oh, just, look at something differently, alternatively than Epogen. So this is another case because we're looking at alternative therapies and then just going straight to ESA therapy or, better with anemia management. So this is a longtime patient of mine. He's 48 years old, ESKD based on IgN, started in-center hemo in 2007, quickly transitioned to PD in 2008, but then he went back to in-center only for 3 months. And then he went to short daily and he was on the Fresenius machine at that time. And then he switched to next stage therapy. And then he did, in 2014, switch to a hybrid therapy of short daily and nocturnal HHD. Because he's young, he had 3 kids, this was what worked out in his life, and we weren't going to restrict him, right? So if you looked at initially over the years when he was on, on in-center hemo and short daily, when initially on in-center, his hemoglobins were low, 8.7, and then increased to 10.6. He was requiring that thrice weekly Epogen. At that time, we were using Epogen on our patients. We decreased it to once a week, and hemoglobins were 10.6. So then fast forward to 2020, he exclusively just went on nocturnal. He got about 30 hours a week, maybe 32 hours a week of dialysis nocturnal. Sometimes 35, sometimes he'd be on 10 hours, sometimes he'd be on 8 hours. He knew how to manipulate everything with that next stage machine to fit his life. And so his hemoglobin increased to 11.4. So no longer, low dose, you didn't need that. At that time, we switched to Airnest. We had gone to twice a month, and his hemoglobin stabilized in the 11, and we decreased it to once a month, which the patient trends to do anyway. So the idea is that more frequent therapy will help, and it'll show you. I could have showed you studies from 1994 with Dr. Periadis and Dr. Udall. I could show you the Bob Lockridge studies. I could show you the Mike Krause studies. Looking at more frequent therapy, longer duration therapy is an amazing way to manage anemia. And you can reduce your epogen doses. And that was one way we were trying to sell home hemodialysis or more frequent dialysis, is you can save money because you don't give those things because of the frequency of dialysis. And Mike is my patient is Mike, and he is a perfect example of that. So because he doesn't require, the ESA therapies on the longer duration therapy. So again, thinking out of the box with patients is what's really, really important. So what do we know about frequency? We know we have a buildup of uremic toxins that reduce the lifespans of red blood cells, as Calvin talked about. And uremic clearance by more frequent dialysis results in increase in hemoglobins, and of course, decrease in epogen requirements. So again, if you, just another piece or another tool to push your in-center patients to more frequent therapy, right? Okay, I want you to feel better in all regards, but you could feel better from an anemia standpoint too by getting more frequent therapy. And anyone who knows me knew I was going to put home dialysis in this talk, just because. So the anemia management for home dialysis included with this U.S. public policy initiative talked about just the advantages of more frequent therapy with anemia management. So again, we look at all these quality of life, all these factors of what more frequent dialysis does, but when it looks like it from the anemia standpoint, we can truly achieve those outcomes with better quality of life, better hemoglobins, less meds. So this was just, I wanted to show you this. This was reported back in 2021. So a little bit of a changing gear here. So what happens when your labs aren't budging? That you're like, Calvin kind of talked about increasing doses. We're increasing. He saw these trends and nothing was happening. We're hemoglobins are staying steady, or they're decreasing. They're staying in the 8s, the 9s. We're not getting them to what we think should be 10 to 11. So we look at some of the causes for that. Was it iron deficiency? We look at iron studies. Was it vitamin B12 deficiency? So we checked vitamin B12 levels. So these are just things that you kind of think out of the box. With folate deficiencies as well, hypothyroidism, look at TSH levels. Do you think about that? ACEs and ARBs. Some potentially correctable causes, infection, inflammation. Again, talking with your patients, knowing your patients, drawing these C-reactive proteins, these CRPs. We do that frequently. Not getting enough treatment, not enough dialysis, blood loss, hemolysis. Bone marrow disorders. One thing that wasn't on here that we have really, been active about is secondary hyperparathyroidism. When you have chronically elevated IPTH levels, you can get, ESA and hyporesistance with that. So when you look at, these agents with this responsiveness for clinical and economical outcomes. And what I just kind of want to highlight is the conclusion of this. This is looked at patients who don't respond despite the fact that we're giving them increased doses. And what we find is that if patients are hyporesponsive to ESAs, it is associated with higher mortality, higher cardiovascular hospitalizations, and of course, which increases high cost. So trying to dig deep into figuring out why you're hyporesponsive, why that patient is hyporesponsive, looking at, what's going on with the patient. Another thing that we look at, and I know Calvin highlighted this a little bit, was inflammation, and how inflammation can truly decrease our hemoglobin responses to ESA therapies. And so, understanding inflammation, understanding what CRP levels. We draw a lot of CRP levels when we see that patients are not responding or if patients have been hospitalized. We actually look a lot at cystatin C and CRP levels in our CKD patients as well. In our AKI patients, we're looking at that more and more. But understanding if you're inflamed, how are you going to get a response? And as opposed to doing a knee-jerk reaction and just keeping increasing epogen doses or ESA doses, think about they're chronically inflamed. What are we doing with these patients? So, it's just understanding that, we have different tools in our toolbox to truly assess hyporesponsiveness. So one of the physicians I've been working with for the last 25 years, his go-to to inflammation is using Trental, 400 milligrams. There's been a lot of studies out there showing that it can reduce inflammation, can reduce inflammation, CRP levels, and when you have high iron stores, these ferritins of 2, 3, 4,000, how can you get this released? Panoxafen, it has been shown to use this. And we have been advocates for it I've been with him 25 years. I know Panoxafen has been out for a long time, but it is one of his go-to when we have these patients who have low T-sats, high ferritins, low hemoglobins. How can we get this reduced inflammation? So this is just a list of studies, something I don't think people necessarily think about because we use it for different things, but we'll see a significant, increase in hemoglobin and hematocrits using these Panoxafen 400 milligrams daily. So getting back, this is one of my last slide here, living well with kidney disease. I really like this slide. I know it's not necessarily I think it could be factored into anemia, of course, but just understanding about patients need to participate in their own care, education, engagement, empowerment of not only patients, but of the interdisciplinary team, and addressing the symptoms and how it impacts their life. So again, back to Nancy and what she said and how she felt. Dialysis is hard. Anemia, and being anemic on top of it, it just makes it much worse. Patients are just so fatigued. And so understanding how this is so impactful with life and understanding how can we create a better life on dialysis with kidney disease. So I appreciate your time. This is the summary of Kelvin and I's discussion with the KDIGO guidelines, which he couldn't show the 2025, but the patient center approach, and then of course using clinical judgment and assessment, and again talking with patients and their care partners on how to manage anemia. So I appreciate your time. We had 7 minutes left.
So when you have the standardized protocols, what kind of barriers do you see in implementing this, depending on, of course, who's responsible for it? Like, say, if you have a centralized anemia manager, what kind of barriers do you see, and how do you ensure that your interdisciplinary team is aware or are aware of when you deviate from these protocols?
No, I can answer that. So the barriers is that the centralized anemia managers look at numbers, right? They look at labs, right? And if you don't have good documentation in the chart, how can they trend the fact that do they know the patient went into the hospital? Do they know the patient had a GI bleed? So that's the barrier, that you have somebody like our centralized anemia manager for St. Louis is someone who lives in Chicago. And so she's looking at 2,000 patients in this big region of hers. So again, and then she calls the unit to ask about Mr. Jones, and you might get a float nurse who's there that day and not your nurse who's always there. So again, those are the barriers when I feel like you don't have an anemia manager who's actually in the unit and knows the patients as well. But if you have nurses and PCTs and everyone who does a great documentation in the chart, a centralized anemia manager will be able to find a way through those barriers because it's all there's with the documentation in the chart. What I find is that centralized anemia managers will automatically make a dose change, or these computer-based ones will make a dose change. And if you're the nurse on the floor that day, you might not, it just pops up. As you said, you had your little scanner, and the next thing you know, it's... Yeah. So, where's the thought process in that for the nurse who's administering that medication? So I find that a barrier in itself. And I don't know if, Calvin, you could speak to this, because you guys seem to use a computerized protocol and it pops up. Does it give you a reason why doses have been changed, or any rationale? You would think about, oh, sure, if the dose goes down, it's because the hemoglobin's gotten better. But if the dose went up, why did it go up?
Ours on the nurse user end is more of the potential reasons to not administer it. So usually blood pressure is the most common one we see. The reasons ends up being the nurse that's actually checking off the dosing from the computerized decision support system. So that's before they even come to the unit. It's the Friday or Saturday before they come to the unit at the beginning of the week for their dose. So yeah, I mean, I think it emphasizes the role of that person at the bedside, I think, right? So just to, even if you take 5 extra seconds, I know no one has any extra time in practice, but just think like, does this make sense, right? Should I really be giving this patient this dose? Has it changed? Has it gone up or down? Does it make sense for my patient in front of me, before that administration? And if it doesn't, that's, that there's red flags, right? There's reasons to deviate, but it just should prompt communication back to either your central anemia manager. We're lucky, we're small, it's 165 patients in our unit. So there's one nurse that runs them all. And they generally know all the patients. So we're a little bit of a unique scenario.
So how do you notify the staff that takes care of
It's in the
patients about
computer.
the change?
It just pops up in the computer.
Yeah.
Yeah, because you have your list of your meds that you're supposed to give that day, and it just pops up in there. But in our home program though, we have nurses who have primary patients, like, anywhere between 15 and 20 primary patients. Those nurses, I forgot about that, I talk loud though. But those nurses do their own anemia management because those are their primary patients. So we have a big home program and we don't have a centralized anemia manager for that. We feel that the primary nurse should manage their anemia because they know those patients pretty well, so.
I concur with that if we went back to and engaging myself here to
Alice, do you mind going to the mic? I was bad, I didn't. But this is being recorded, so if you please go to the microphone.
Oh yeah, for the recording.
Back in the day, so to speak, we had all primary care nurses. And so the dialysis staff were assigned, the dialysis RN was assigned X number of patients. And whether they were there or not, even if they were, on PTO or they called in that day, they managed the entire patient. And they all knew, I forgot that there was that microphone there, and they all knew their patients and they made the changes. And I could say for all the nurses that, in a dispersed workforce that are coming in, many of them do not know anything about anemia management. And so I changed it to anemia protocol. Just adhere to the protocol and decide whether or not the patient should go along with that, because the management part seemed to belong to someone else in the unit as we siloed these nurses, that they don't do QAPI, they don't do anemia management. That's not what I do. I do direct patient care. I'm also seeing on another comment is an uptick on oral iron as our patients are living in dispersed areas. And we are providing education to non-dialysis nurses, and they know that iron should be given. I'm seeing on multiple MARs across the country oral iron because they believe that the patient should receive oral iron. And I think that's something that we need to look for. My other question, I have one more question, is patient received a transfusion. Their hemoglobin has decreased. They get to 6.9. Many facilities, depending on where they live, just has a cutoff. Anything below 7, you get an iron transfusion, and they're not looking at the trending. But yet then in 2 weeks, when it comes time for a dose change, because it's been 4 weeks since the last one, they decrease the dose because you may not be aware that there's iron, or based on the protocol, you're decreasing the dose. So now you have that curve and that, up and down, and the patient then, what we've been tracking is 6 weeks later, 8 weeks later, they need another blood transfusion because the blood transfusion elicited that you're going to decrease the ESA, decrease the ASA, it goes down, another blood transfusion, and they go up and down. So we have to be mindful of that also.
What I have also been seeing is that since there's been some instability with nurses in the clinics, like a lot of float nurses trying to keep retention of nurses, there's been this notion that I've heard is maybe dietitians should take over anemia management in the clinics because you have a more stable RD, consistent RD who's been taking care of those patients, as opposed to the fluctuation or the revolving door of a nurse in the unit. I'm not an advocate. I'm not saying I want to take that. I feel like it should be the nurse who's managing. The nurse is on the floor and sees what's going on, and they should understand, and I think there's a lot of legality to an RD writing an order for, ESAs or iron. So this is what I'm seeing because of our nursing problems today.
I just want to share my physician's perspective. So, Cal and Lisa, great talks. Thank you.
Thanks.
So, two comments basically to your point about ESA hypo-responsiveness. I just want to share my experience. Sometimes becomes very tricky. I had a patient many years ago. We just had to pay attention, very close attention to the patients who have, after failed kidney transplants, who come to the dialysis units. Sometimes, basically, they are that kidney that sits there, gets inflamed, no symptoms. And patients, I had a patient like that comes with severe hyporesponsiveness, and you do all the workup in the world, nothing comes up. Nothing is positive. I had a patient who actually did the workup. I said to hematologist, bone marrow biopsy, nothing. And I couldn't think of anything else, so I just no symptoms, abdominal symptoms. I scanned his abdomen. It was huge, inflamed, transplanted kidney. I sent him to a transplant center, explanted it in 1 month, everything corrected. Just one comment. Second comment about anemia management. I agree with you that centralized anemia management is not a great tool to be focused on the patient needs. I'm lucky because I'm actually I work in a hospital load, one of those few left hospital units. That's why nurses are assigned to that, and they come to me. I'm a medical director of that unit. They come to me if we have a nurse assigned to that. If they have a question, they come to me, and then we know the patients, and you cannot blame the centralized managers because when they manage 2,000-3,000 patients, how can they cannot provide individualized care? So that's a problem. I agree. So, thank you.
No, I agree. We're one of the few hospital-based clinics out there too. And so we have these meetings. We have anemia management meetings. We have mineral bone management. So the interdisciplinary team is there, and we're putting our heads together to look at this. So, I mean, that's the beauty, but yeah.
Both great talks, and it's useful because I haven't written an ESA prescription in 10 years, so let's get back to it. But it does bring up a very valuable point that I think you both touched on. As we go to computer-based, frankly, they're better than doctors, right? In general, for 90% of the patients, they take care of the variability, they lower the ESA dose, they get more iron in the patients. Makes perfect sense. As we go to AI, maybe we'll get up to 95% of the patients. But what we forget, whether it's a DO or a small dialysis unit or whatever, is that you need that human touch, you need that human experience, right? Does the patient have a transplant, need transplant nephrectomy? I cured anemia by sending him to the dentist and treating bad gingivitis, right? I can't do that with AI, I can't do that with computer, I can't do that with a centralized, which doesn't say they're bad. The question is, how do you at your unit and your units figure out how to educate the patients and the nurses, right? You pointed this out, the nurses don't understand anymore. That's unacceptable. So how do you propose to change that and make sure that we as a group of people taking care of patients understand that AI isn't the answer, it's part of the answer.
Yeah. It's just a tool, right? It's a tool to help. But yeah, I mean, it's an excellent point, right? And it gets back to keeping the patient at the center of everything that we do. And it should be, don't use the tool as a crutch, right? Use it to help you and make a decision with the full context of the patient. Who's that person sitting in front of you? And don't just think, oh, centralized anemia management, they take care of all this. It goes out of my brain. No, you still have to think about it. Every time you administer the medication, go to the patient, you have to think about those kind of things because there are a lot of these sort of indolent causes of inflammation or other reasons for ESA hyporesponsiveness that no tool will catch, right? The person with the rapport and the relationship with the patient will catch it. And so that's an excellent point. And so, I mean, I think at my unit, what we try to do is we do a very good job educating on risks, right? So ESA risks, and iron infusions and iron infusion reactions are becoming more, the education there is becoming a little bit stronger, I think, for patients as well as the nurses and the techs. And so we're just trying to make sure that we bring to the forefront, like, these are your options, these are the potential risks associated with them, and this is what we can do. We have a lot of maybe unique patients that get referred to us, since we get a lot of people who maybe don't want to abide by the protocol, right? I've had patients who demand their hemoglobin to be above 12. They don't care about the risks. They'll sign a consent. They'll say, no, put me above 12 because I feel much better there. And so, we'll accommodate those when we can. And so I think it's just, you got to know your patient. You got to keep them at the forefront.
I think we have to quit our discussion
Oh,
because
but-
it's time, but I have
yeah.
one last question. How do you get away with your grandmother with a 9.1 hemoglobin? How do you get away with the quality measure? That's, we know that anemia management is one of the quality measures that we look at.
Yeah, I mean, then that gets to the point. So the patient I'm thinking of was actually a former colleague of mine that was a hemodialysis patient that demanded their hemoglobin be 12 and 12.5, and that's another, at the time was a quality measure. And so, there's a lot of pushback, right? And so then you have to balance your units, quality and tied reimbursement to, these things. So it's a challenging situation for sure. My grandmother, they tried to push to 10 to 11. They tried. She never got there, unfortunately. But
What Lisa didn't tell you is Nancy always said 13, and she'd get up in the microphone
Yeah.
to tell you for 15 minutes why it needed to be 13.
yeah.
Exactly right, so.
Yep.
Well, thank you very much.
Yeah. Thanks, everyone. Appreciate it.